Well, good afternoon, everybody. Thanks for inviting me along here. It's a great privilege to come along and talk to you about something that has, as yet, very little in terms of body of scientific evidence. So I lay myself bare on the floor here for you all to challenge everything I'm about to say. I am a physiotherapist, and I know there's a number in the room, so you can't have too much of a go at me for that. But I do live and work in the leafy area of Northumberland. I've got a clinic there. I used to have clinics all across the southeast. I'm originally from the northeast, and my wife and I decided to move back after our third child. So I sold my practices in the south, and we've moved north. And I have a very busy practice, and I use Shockwave a great deal. I found out about Shockwave because one of my clients, who I'm allowed to mention, it's a bit of a name drop, I apologise, but Paula Radcliffe was using Shockwave. She introduced me to the concept. I then used it on another one of my clients, Steve Cram, and it worked very, very well. I was one of those people that read all of the research back from the early 2000s and thought that it didn't work. I actually, as an undergrad, did a study in shockwave and plantar fasciitis, and a lecturer who I thought was the pinnacle of scientific research, knew everything, said to me, it's a load of rubbish, don't go near it, and didn't even want me to submit the piece of work. So I stand before you today having been on that side of the fence where there was perhaps a lack of evidence, and now I'm using it as much as probably anybody else in the room, bar one, and I'm getting some great results from it. Some of those results, I will tell you, are based in where I believe the scientific evidence is, and some of it is based in anecdotal evidence. And I know that we hate anecdotal evidence, but if I were to ask you a show of hands as to who got into the healthcare industry to make people better, and who got into the healthcare industry to be too concerned with science, and we might get a room split or divided. I want to talk to you about radial shockwave therapy in relation to the spine. And we're going to look at two different applicators, which I know not too many people are using. I've been using them for over a year. I do believe that I get fantastic results with all the other scientific parameters and weaknesses that surround that, in that I'm not just treating them with shockwave, I'm also doing physio and exercise. But I do believe that my results have improved significantly since I've been using these pieces of apparatus. All right? So I'm happy to field loads of questions. I'm getting more and more used to being in this room. It's the second time of coming here to this conference, and also today, much more used to people saying, I don't know the answer to that, I don't know, I don't know. I will try and tell you what I do know, but I can't back a great deal to do with the spine up with a load of science. So cut me some latitude on that, if you will. So, and at Corbridge Physio, for those of you that like Twitter. This should have moved on. Okay, so I don't know how many people have really seen the new NICE guideline, or the new NICE guideline that's supposed to come out for back pain. Show of hands who's read into that? Just a couple of people, yeah? Well, until a couple of weeks ago, I also fitted into that. NICE guidelines are a good gauge, and I've heard them mentioned a couple of times today in terms of it was a big thing for shockwave when Achilles and plantar fasciitis were accepted again by the NICE guidelines. It is basically one of the factors that we do need to bow down to, and so it's interesting when we get new guidelines out, although arguably the 2008 guidelines on low back pain were vastly under-adopted, so I don't know what will happen with these. But I was at a talk a week ago with the Northern back pain kind of group, and they're kind of spearheading a new policy, if you like, that's going to happen across Northumberland in the way we deal with back pain within their NHS. So approximately 30 million days are lost because of back pain or MSK problems. Largest cause of disability, no surprises there. The prevalence for a lifetime is 84%, chronic low back pain at about 23%, and 11 to 12% of all disability is being put down to low back pain. So we've got a massive problem, everyone agrees. Draft guideline is saying that certain things that previously were in are now out, and certain things that were previously in have now been modified slightly. So it recommends exercise in all its forms as being the #1 treatment for particularly chronic or non-discriminate low back pain. This is seen as the thing that will kind of become the figurehead of all of that, alongside talking therapies, which I'll talk to you in a minute. Manual therapy, massage, manipulation, should only be used in conjunction with exercise therapy. All right? It also recommends that people are encouraged to go about their normal activities as much as possible. Movement is good, don't sit still. Way back when, we all remember being told that if you had a really bad case of back pain, that you should go and lie on a door and stay still for 6 weeks. There are many people in the room who remember that. In fact, one of the only people that probably got better from lying flat on a door was the person that took it too literally, actually took the door off its hinges and carried it upstairs to bed every night, and probably that exercise of carrying his door up and down is probably what helped him more than anything. Back pain should not be discussed in a disease model. Moreover, they are suggesting it should be likened to flu. It's horrible, it's so painful, you think you're going to die, but you don't, you get better. Okay? Now, I know when I was listening to this, it was kind of rubbing me up the wrong way, but I just want you to stick with the fact that the things that are in are exercise and manual therapy. Acupuncture, it's on the fence actually, but it looks though acupuncture is going to be out for low back pain. Paracetamol is out because it's actually ranked the same as NSAID, so if you're going to take a drug, then they'd much prefer that you use a non-steroidal anti-inflammatories, so they're very much in. Weak opioids, such as codeine, are seen as being out. People have been getting some very, very kind of end-of-life type medication for really bad back pain, and I think what the guidelines are saying is we want to start drawing back from the drugs and using them more appropriately. Codeine and opioids recommended for acute back pain when NSAIDs haven't worked or aren't suitable. So talking therapies. So the idea is that what we say has so much value. So I go back to the disease model, and that is that if we talk to someone about the fact that something is out, or it's wrong, or it's broken, or there's something they can find as an actual pathological thing within their spine, that these people are taking a lot longer to get better. We're dealing not just with their body, but we're also dealing with their brain. And a lovely statistic, which came out of the talk I was at last Wednesday, was that people who have an MRI scan for back pain get better 200% slower than those that don't, because you've given them a thing, something to focus on that is wrong, and they don't know when it's better until they get another MRI scan that says it's better. And we all know the limitations of imaging and the likelihood of that actually being an outcome. So we are dealing with patients who want to know yes or no answers, and we can't give them to them. And Professor Romp, who spoke here right at the very beginning, something that he said stuck with me from last year. He said, be the first person to tell your patient the truth. And sometimes it's a hard conversation to have, but I think that what this nice guideline is saying is actually what we say is so incredibly important to the outcome, that we should be thinking about the sort of way we interact with our patients with back pain in relation to the way we present it. You are going to get better from this. This will get better. A huge percentage of people get better from back pain within 6 weeks. The people that don't get better within 6 weeks, we've got manual therapy and we've got certainly some psychological support, but we've also got various medications to get you through that point in time. So where does that leave us in terms of what we can do? Research has shown that our current thinking for first-line therapies probably there isn't enough there to be conclusive, so they're changing what we're supposed to be doing. They support manual therapy and exercise. So the reason for introducing this to you is that I really want to offer you something that might, just might, be another alternative. Because what does manual therapies mean? For some it will mean massage, for some it will still mean acupuncture, others it will mean grade 5 joint manipulation, others maybe grades 1 to 4 mobilization, trigger point release, and everything in between. I've been using Shockwave a lot. I use it on all the stuff we've heard about, Achilles tendons, plantar fasciitis, patella tendon, gluteal tendinopathies, elbow, shoulder. I've worked on everything and I get great results. For the last 12 months, when people have come in to see me that have had a range of different levels of back complaint, I have offered them the opportunity to use shockwave therapy in the form of the spine-actor and the PERI-ACTOR, which I aim to do a little demonstration of shortly, if we can get someone to agree to come up and take part in that. And there's a couple of great anecdotal stories that I could tell you, and I know that we'll all sit there and go, but it's anecdotal, and what does that mean? But there was a chap that came in who was knocking all the pictures off the walls. He was one hand on the floor, one knee on the floor, tears in his eyes, in unbelievable amounts of pain. So he's got a huge lateral shift. We could have the whole disc in, disc out debate as long as you want to, but he had a huge lateral shift. He was moving away from pain. He was in agony. He couldn't stand up. He was the owner of a pub and needed to go back to work, and he had to lift barrels and all the other stuff that we have to deal with. We tried, you know, the massage, the acupuncture, the standard sort of low-level manual therapy, and it wasn't making any difference. I offered him the shockwave. He said, anything, I don't care how much it costs, I'll write you a check right now, just do it. So we got consent, and we used that, and the guy walked out nearly straight. I wouldn't say he was pain-free, but within 6 weeks of that exact treatment, the guy was 90% pain-free. He hasn't come back. I'm in constant contact with him, not because I go to his pub all the time, but I'm in constant contact with him, and this guy got better, and he attributes it to this. And I've got lots and lots of other stories like that, where people come in, and it really does work in front of your eyes. So whether you want to think of it in terms of there's no science behind it yet, what's it actually doing, I'm fine with that. I had to be fine with that, and what I'm now doing, going forwards, is actually going to start doing some research on my own based upon the findings of the Nedelka study, which is 2014, where shockwave is seen to be as effective, if not more effective, than facet joint injection. And I've given you please make this available to everybody, but you can go and look at that paper and read it. And that kind of buoyed me on to the fact that we were sort of onto something here. And I've also got 2 undergraduates that are working in my clinic, and we're going to do a small study as part of their degree. One of them's going to look at OA knee and radial shockwave, and the other one's going to look at the spine actors and chronic low back pain. And we need to have those results in for their degree by the next 6 to 8 months' time, and I'd love to share those very small studies with you. I've spoken to Gail Maffully, and we're agreed that in 2017 we're going to start, part of the ASSERT protocol, a study with everybody that has the spine actors and the PERI-ACTORs to actually try and move this forwards and gain some evidence. Somebody once put a needle in the skin for the very first time, and then it became acupuncture. Somebody once did the very first surgery. With this stuff, I believe there is enough that I've experienced myself to warrant us looking into it more. But that is the best that I can offer you in those terms. So, a bit of practical stuff maybe. Are you all okay to stand and come closer? And is there anybody who's keen to lift a top up a little bit, a lot, to take a top off? Can you just get the, just go the whole hog? Yeah, yeah, just get yourself naked. I say, great that Johnny's agreed to do this, otherwise this would, this next section might have been quite short otherwise. Just lie face down for me. I'm just going to show you how I apply it. We're not doing a full kind of clinical analysis here at all. So, has everybody seen the spine actors first of all? So how many people here actually use a shockwave machine already? We got anybody on the fence thinking about getting one? 2 people? Okay. So typically, I mean this is the same MP100 that I use. Typically with a shockwave, you end up with your gun that you get, call it the gun, and you've got your normal kind of piece for your radial shockwave that goes on the end. It's quite a while before I realised you could sort of temper around the different heads, so I was always using the R15. And you get a clutch that just screws on there, and then this is where you can put the spine actor in. So we've got 3 different sizes, basically small, medium and large, and the idea is that the small would be purely cervical spine, the medium you could use on a larger cervical spine or through the thoracic, and the larger one would be lumbar or on a larger thoracic. Yeah? So if we just go straight for the lumbar one, you can, with most of your M pieces, switch the machine on and have it working around your head. However, because of the fact that this is moving backwards and forwards, actually creating the mechanical pressure, it's best not to, because I'll be concerned about it flying off, and this looks like a beautifully painted ceiling. And some of you might claim against me. All right? So we do use a contact solution on, a little bit either side of the spine there. You don't need loads. Settings-wise, there is a sheet that I've got that actually came from Venn, so I'm sure they can share it with you, but I'm actually going to be doing a protocol that I think is going to be most relevant for the study, and I'm using a 2.2 bar, 3,000 shocks on 17 hertz. Yeah? So it's quite high, not at the full depth. What we do, a little bit of solution. You're going in at about 45-degree angle, and away you go. You're just moving up the spine. Now, whether this is of any relevance or not, but you tend to find that the machine slows down. You feel resistance around the spot where there's quite a lot of tension there. And if, Johnny, you feel that the same. And you just guide the head through till you approximately reach the end of the plan. Now, I'm not going to go through all 3,000 shocks. Very happy for other people to come up and have a go. That's fine. That's the way that I think this was probably intended to be used, but I'd never do that on its own, okay? Because we also have this group of PERI-ACTORs here, which I suppose if you are someone who does a bit of soft tissue as part of your treatment plan, you might think about getting your thumb stuck into QL, you might think about doing a bit of trigger point work, you might be looking at loosening off the fascia. So to stick with the Shockwave theme, there's various attachments that you can use. This, I always call it the wrong name, scraper I think it's called, I call it the T-bar, is the one that I use predominantly to go alongside and go through the paraspinal muscles just to loosen those off. So I'm sticking with the same energy, again a 45-degree angle, pretty firm pressure, and the same as you would do if you're using your fingertips and hands. When you came across something that felt a bit like a trigger point, I might come out, see if I felt that as a trigger point, then I can switch heads out and go for the sphere, just caught the name on the way in there, and then this works a lot like trigger point therapy, going into the trigger point. Now I could do an amazing parlour trick for you. We could have got Johnny stood up, we could have looked at what a terrible test I know, but forward flexion was like, and I could do this, and I could every single time show you had greater forward flexion. But I'm not looking to give you some kind of parlour trick. I'm trying to introduce you to this as a concept. This works very, very well in my practice. I believe that I'm going to get some tremendous results from the upcoming study, and I will treat the whole spine. Now, one thing that I also have done is to use the radial shockwave head on the paraspinals. Yeah? Now, I was fortunate to be invited to go and listen to Kareen that came over from Storts Medical at the Welsh Rugby Union earlier this year, and I'd been going along with the thought process that shockwave therapy should be 500 shocks at 1.5 bar, then 2,000 shocks at 2.5 bar. That was the setting for musculoskeletal disorders. And she opened my eyes to the fact that whilst I was working on perhaps someone's Achilles at the 2.5 bar, and they were finding it untenable, it was so painful they couldn't cope with it, she said it's okay. You want the person to feel a bit of discomfort, but they shouldn't be screaming in agony and making it very horrible for them. So she switches the heads around, she changes the number of shocks per second, she moves the parameters around to fit the patient, which is why I was making a comment earlier about the fact that I think we can get too drummed into what the actual numbers are doing. You have to, in the same way as you would change the depth of a massage treatment, or you might change the depth of a mobilization on the spine, I think Shockwave needs to be adapted to the patient. They should feel a sensation, but it shouldn't be overly painful. They should be able to cope with it. I, across the board, do 6 sessions of Shockwave, and I normally find that people are feeling a great deal better after session 5, and I normally feel that by session 3, I'm getting to the kind of dosage that I want to if they're a particularly sensitive patient. You might have allodynia, all sorts of things you need to cope with. Centralised pain is alive and well, as we know. This isn't a pain lecture, but I don't believe there's any chronic condition that doesn't have some of its seat in centralised pain sensitisation, and so we're dealing with the whole package. This works very well with that centralised pain. If it's doing anything to reduce down muscle tension, if it's doing anything to impart on the tissues, the things that we think that Shockwave does, then great, but I'm absolutely certain that there's a hyperstimulation in the nervous system, which in turn is reducing people's pain. As we know, drugs are designed in low back pain to reduce pain so the person can move, because movement is the greatest thing they can do to get them going, to give them the confidence they can move and they're not stuck that way forever, and this helps that. Well, I'm providing the nice guidelines there. I think non-steroidals negatively affect the healing process anyway. I'm sure there's a few people share that. Some people will go against it. So I would rather, if we could, that they didn't use non-steroidals. I think that people can get a lot of benefit from ice and heat, which are having far less impact on the gut and all the rest of it. And I think there's a tendency to say, well, can I come off these pills? You get people come to you and say, I don't like taking pills, people that want to take them all the time. 2 days without non-steroidals after the Shockwave. Because we're creating a response, we're creating a pro-inflammatory response, and I don't want a medication to take that away. But if they're stuck on them, 5 days in between their 7-day treatments, they can go back on them. I don't want to get into the SIJ debate, but yes, I do. I actually, it gets quite noisy to do this, but I'll use the middle head or the small size head, and I'll actually go around the SIJ. Yeah? Now, whether you believe there's movement there or not, whether you believe it's a therapeutic thing, happy to share that in private, what my feelings are, but I do work a lot around looking at somebody's symmetry and deciding if it's clinically relevant to their symptoms. And if I think there is dysfunction at a sacroiliac joint, I get fantastic results through somehow correcting that dysfunction by using this. I also do manual mobilizations. I also do a whole load of soft tissue around the glute medius, minimus, everything that attaches in their QL. And I genuinely believe that I see an improvement in function from it. Right, so I was delighted to see that the first talk was going to be about acute injury, because I've been using Shockwave on acute injuries pretty much since I got it and got the confidence to use it. There seems like my desire that first lecture was going to tell me that everything was great and to march on forwards and keep doing it, but it seems that the jury's out. But I think there's very, very exciting applications for Shockwave. I don't want to say it's a panacea cure-all for everything, but I do find that I'm getting much better results. Now, how much I'm working on Johnny's head and how much I'm working on Johnny's tissues, if the patient feels better, they walk better, they stand better, and they think I'm a better therapist as a result of applying this, then I'm afraid in the face of conflicting evidence, I'm going to do it time and time again, because I got into this gig because I wanted to help people and I wanted people to feel better. And however I get them to that point, I think this is safer than massage, safer than acupuncture. I think it's about the safest modality that we use. I know a few people, and where's Nicola gone? Trevor Pryor is a good friend of mine, and some of you may well know him as a podiatrist. He refers to it as a no-brainer. I mean, he is cranking it up to some pretty high bar pressures, but he considers it no. Say again? Why safer than massage? It's certainly no difference to massage, is it? If you look at the list of contraindications to massage and look at the list of contraindications to Shockwave therapy, it's a shorter list.
Have you used it post-surgical spinal surgery?
Not yet.
Down the road,
I mean. I have people that have had discectomies that I use over, previous down, but I've not used it as part of a protocol as rehab from a surgical process. I haven't had the opportunity to. I've been at 5 bar into a glute. There's a lot of tissue. I'm working off the basis of the feedback from the patient. And I've had a deep impact head for a professional rugby player on a 5 bar going into his glute, and it's the first time he could feel it. And we tried every setting before that. And I said, you sure you want to go for this? He goes, yeah, absolutely go for it. I've had a 3-day eventer who couldn't ride a horse straight because of an Achilles, came in because he thought his back was out. We love that term, don't we? And turns out all that's happening was he didn't have enough dorsiflexion, his Achilles was too tight, so his knee was forward, so his hip was rotated, and he couldn't make his horse go in a straight line. And we treated that, but he was made of stone, this guy was. So, just as Corinne gave me the confidence to do, I kept the pressure going up until he could feel the sensation. That guy had 6 sessions, 3 of which were at 4.5 bar pressure. Now, I know you're not going to find that in any book, anywhere. He didn't rupture, he did get better. A quick example of someone that came to me yesterday, 14-year-old lad, as far as best I could see, acute torticollis of the neck. I didn't end up using Shockwave on him, but his mum sat there going, we've come to see you because the other person he goes to see says his neck's out. He gets a click from the neck. As he gets in the car, he hears a click. He goes, Mum, it's out again. We need to go back again. And it's in, out, in, out. The way in which we talk to our patients, the kind of images that we put in their mind about what we're doing and what we're trying to affect can be completely damaging. That little boy, I got his neck moving 100% perfectly. His mum saw it, I saw it, he saw it. He walked out, realised he was going the wrong way, and he's doing this again. You know, that is ingrained in a young man as to what's wrong with him, and he feels he shouldn't move his neck. And I'm going to try and work with him to try and break down through those barriers. But that's a far bigger risk to that young man than anything that we do. The words that we say have a far bigger implication. And I'm sure there are stats that say that if you're a very charming, charismatic, and good-looking therapist, that you get greater results. And if you engage with your patient, all that sort of stuff, we can find results for everything. All I ask is that, given the new NICE guidelines saying that we're going to start having one and then the other hand tied behind our back about what we can do, if we could get more people at least trying this, I don't know, I'm going to throw but loan units, anything, I don't know, I'm looking for, but just to try it and see what happens with your patients, I think that you will find this as a really nice avenue for those patients that maybe you tried everything you normally do, they're not getting better, right, let's try some Shockwave, yeah, here's the bill, you do it and see it for yourself, because I don't want to be evangelical about something. I just wanted to come here today. I'm very honoured to come and talk to you guys, actually, but I wanted to come here today to share my experience.